to invite the FIGO President, Dr. C.N. Purandare.
Let me at the outset thank you for inviting me to come here for the oration. And it's a pleasure to have Kamini there chairing this session today where I'm giving this oration for your Congress. I promised Shobha and Alpesh that I will come for this conference. Due to so many things that are happening, ups and downs, I had to literally cancel it, but I said that I will make sure that I come here on a Sunday in the morning and go back in the afternoon because I'm flying to London tomorrow night. So it's a pleasure to be here in Bangalore Society, and it's always a pleasure to be in Bangalore and with Hema Divakar there sitting in front of me, who is one of the co-chairs of the NCD committee of FOXY, of FIGO, which we formed just 4 months back as an official committee. It started as a working group. Last year we sanctioned it, and then the official committee has been formed with the NCD, and she's the vice chair of the NCD committee from India, which I'm very happy to have her there on the FIGO's roster. Now I'm going to talk today on NCDs, because NCD is now considered, as far as from MDG to SDG, as one of the very important factors. And at the WHO level, NCD has been given the topmost priority, in which not only diabetes, hypertension, but cancer cervix is also included as one of the areas which need to be seriously looked into. So when you look at NCD, as far as the diabetes is concerned, the vicious cycle of pregnancy-induced complications and the non-communicable diseases that are there, they all start in utero. And that has been forgotten, and that has not been understood by most of the obstetricians, that the whole scenario starts with the mechanism of the functioning of the baby's system, which starts in utero, and that really reflects subsequently as an adult. Now, nutrition has been traditionally neglected as an entity. We hardly inform our patients what needs to be taken during pregnancy, the healthcare system for women and children, as to what nutritional value it is, as far as the maternal nutrition, which transfers into valuable, important elements to the baby for its growth and nutrition that happens. So it has a central role in determining health across the life course when you look at the situation starting from the essential central position to the various entities that are there. Now, when you look at the MDGs, which were adopted in 2000 by the United Nations, and which ended in 2015, dealt with the important targets for improving health in general. And we are talking about now going a step further when you're looking at the MDG 3, 5, and so on, the SDGs which are now in existence. So these original MDGs which were there as 1 to 8 are now divided into going into the Sustainable Development Goals as far as United Nations General Assembly's resolution in 2015 for the next 15 years, that's what we need to achieve. And when you look at the spread that happens in SDG from number 1 to 17 as to various aspects of it, and you see number 3 and 5, the gender equality and the females, as well as the number 3, which deals essentially with obstetricians and gynecologists that need to look into the in-depth of all the situations. So by 2030, end all forms of malnutrition, including achieving by 2025 the internationally agreed targets of stunting, wasting in children under 5 years of age, and address the nutritional needs of adolescent girls, pregnant and lactating women, and older persons is something which 2.2 goal wants to achieve as far as SDG is concerned. And in 3.4, it says reduced by 1/3 premature mortality from non-communicable diseases through the prevention and treatment and promote mental health and well-being, which is again a very broad aspect of what we need to deal with. Now in 5, it end all forms of discrimination against all women and girls everywhere. That's also part of our entity as far as looking into it. But the global strategy, when you look at for women, children and adolescent health, which is from 2016 and 2030, which other than maternal and pre-pregnancy nutritional initiatives, which are important in making sure that the baby gets the right thing in utero so that it performs well after the delivery. So an end to preventable maternal, newborn, child and adolescent deaths and stillbirths by 2030, and a grand convergence in health, giving all women, children and adolescents an equal chance to survive and thrive as far as the growth is concerned. Now, we have to commit to action, to making sure that this is achieved, and the academic and research institutions at all levels will advocate for targeted in-country research and increasing budgets for research and innovation, and strengthen the network of academics, researchers to promote knowledge and exchange, which we need to undertake when we have all these deliberations which are happening in various congresses and conferences that we are in. So there are two aspects of it. We have undernourishment and the overnourishment. And you are finding that overnourishment is again a major issue coming up, and you have saw the presentation on obesity and cesarean sections, which was never heard of 30 years ago. You would never see a woman that fat to have an undergoing a cesarean section, but you see that happening so very often now, and in America and Europe regularly, and it's not something which is a non-entity as the underdeveloped world and Africa may be. So you have the ending the childhood obesity that needs to be looked into, and basically what you need to look at is the female gender, the key to diabetes prevention, which is transferring the situation from mother to fetus, and that fetus eventually getting diabetes. And if it is a female, you're going to have a female who's going to have diabetes, going to produce more diabetic children, and so on and so forth. And which is the low birth weight to gestational diabetes, which is large birth weights that you're seeing, and in the adult life to the international transfer, the intrauterine gender transfer that takes place within that risk that is taking place. So you have the maternal health and impacts of NCD burden on fetal programming, which is happening intrauterine. So that programming which is taking place while the growth is taking place, whether IUGR or macrosomia, when you look at the predict development of the HTN and type 2 DM and IGT, you have maternal undernutrition with maternal stunting, anemia, malaria, and other medical conditions which result from Barker's hypothesis to the low birth weight that results. And the other side, the maternal overweight, obesity, diabetes, and the excess weight gain during pregnancy, which is the Pedersen's hypothesis of macrosomia, which the results ultimately in the prediction of the development. But the solution really lies in the life course approach that one has to take and one has to inculcate as far as the growth patterns are concerned. Now, when you look at the life course approach to prevention, the inadequate response to new challenges and the plasticity that you see from mother and infant to childhood and adolescent area to adulthood, and with no intervention, what is happening to early intervention, which you see the dramatic drop that you see with early intervention that takes place. So FIGO has a vision. FIGO decided that the objective and this presentation was to describe the relevance of maternal health in the context of diabetes and other NCDs, describe the barriers operating at the individual level, societal level, health system, and at different stages of GDM care, which we are looking at, and show how the proposed FIGO HIP initiative addresses these barriers in its recommendations and suggests possible solutions to overcome the barriers. Now let us look at the window of opportunity that we have. A pregnant woman coming to you is a woman who is going to come earlier in life, and it's important that that window of opportunity that you get to provide maternal care services to reduce the traditional maternal and perinatal morbidity and mortality indicators and address the intergenerational prevention of NCDs such as diabetes, hypertension, cardiovascular disease, and stroke when you make sure that they don't happen. And to just give you an idea of what is happening as far as the incidence of diabetes is concerned, we're expecting that between 2010 to 2030, 73% increase in adult diabetes numbers in developing countries are likely to happen. And look at what today, what maybe those who are seniors here who have seen patients maybe 20, 30 years ago regularly, never saw as much of diabetes that you see now. And today in India, we have 17% pregnant women who are hypoglycemia in pregnancy, which is a large number. And China has 19%. And these 17%, if we don't treat them in time, will have the programming happening in the baby, which is going to result in the baby eventually getting diabetes, and therefore cascading effect of diabetes that is going to happen overall in the growth pattern as far as the babies are concerned. Now, during the last 25 years, the prevalence of diabetes has multiplied 3 to 5 times in India, Indonesia, China, Korea, and Thailand. And China today stands at 19%, which is large when you're talking about 1/5 of the pregnant women having diabetes. And the investigators showed a rising prevalence with increasing age and the increasing body mass index, confirming the relationship between obesity and diabetes. And the terminology now as diabesity, which has come in, which is diabetes and obesity combined together, which is causing the major issues as far as the growth is concerned. So you have the primary prevention that needs to be done, which FIGO recognizes that the obesity and PCOS lifestyles, the secondary prevention of GDM diagnosis and care, and the tertiary prevention to prevent long-term complications of the diabetes. Now, we are all aware that 35 years ago when I started practice here in India, we found that maybe every year I would see 2 or 3 patients of PCOS. And maybe we were underdiagnosing, but still it can't be that today what we see every 3rd patient who has PCOS, there is a huge change due to the lifestyle and life changes that have happened in this country as well. So with diabetes affecting ever younger ages, the concern of an epidemic in cardiac, vascular and renal disease is very real, because that is the combined effect that is going to happen. And the emphasis now must be addressing both diabetes and obesity in a systematic and complementary way, and not as 2 conditions in isolation as you see as diabetes and obesity. Now, the generational transmission of diabetes is maternal obesity amplifies the risk, and the maternal obesity increases early death before the age of 60 by 30%, 35% in the offsprings, which is a large number again. So the women's lifestyle changes need to be adjusted right in the beginning. And the risk of type 2 diabetes as a function of BMI, you can see the change that is seen with adjusted relative risk of diabetes. The true costs of the obesity epidemic will only become known when the current overweight and obese young people get older. Now, when they get older, the cost of treating them with cardiovascular disease and all the other epidemics that will happen, and they will contribute to the type 2 diabetes epidemic, which will in turn fuel the cardiovascular and hypertensive disease and a huge epidemic that is likely to follow subsequent to that. So the therapy begins in childhood with dietary restriction, increasing the physical activity and exercise, reducing the sedentary behavior, modify behavior, and the most important, reduce TV viewing and computer games in children, where they are eating chips and potatoes all the time and putting on weight, not going outside to play a big game of badminton or tennis or whatever, and they prefer to watch on even their mobiles the various Google pictures that are seen there. So most importantly, it is to eat well, be active, and have fun. You can prevent type 2 diabetes. Integration of services, record keeping and tracking mechanisms, building outreach activities through community health, and promoting healthy lifestyle among adolescent girls and pregnant women to avoid both excessive and deficient nutrition and limitation of adolescent pregnancies, which will make the changes. So the barriers to improving diabetes-related MCH is the individual, societal, and health system, which needs to looked into in a complete total manner rather than individually at one individual separate item. And the individual level, you have to access to care, to empowerment, convenience, and financing that needs to be done. And I'm happy to say that at least the government of India has realized the importance of what is happening with diabetes in pregnancy and diabetes as a whole in the population, to make sure that this support system is given to everyone and make sure that the burden is reduced. 48% of the women make less than 3 antenatal visits in our country. We have 47% births are professionally assisted and 19% births are at home. So we have 80%, we have managed to get the 80% hospital deliveries in this country, reduce the maternal mortality. I'm happy to say that just 2 days back, regular circular has come out of WHO to show what India has done, which is phenomenal, with a 5.5% reduction every year in the last 4 years, and expecting that within the period of 10 years, we will go below the SDG level that we are asking for to reduce the maternal mortality. And that is a phenomenal change, and I think all of you have contributed a great deal into reduction in maternal mortality. It's not only government money or talk or whatever, it's on the ground that the working that happens as far as obstetricians are concerned, that make the difference as far as the reduction in maternal mortality is concerned. So the individual barriers to screening, their dependence on other hinders decision about own health, household chores and other responsibilities. There are still women, today we saw on the critical transfer, people being transported on hammocks and in chairs and so on. So we are still struggling a lot at the rural level, where even though the 108 ambulance has been a great achievement as far as the reduction in maternal mortality is concerned, and the eventual cost, clinical timing and distances, and lack of timely or proper mode of transportation, and the woman is completely lost in these situations. If she is staying so far away that she can't go for an antenatal care, where are you going to have that date of 9 antenatal care and whatever, because she cannot reach the place where the antenatal care is being given. Not only that, when we are looking at hyperglycemia in pregnancy, it is understood that it has to be checked very earlier on in pregnancy, and in all Asian and Mexican and Chinese and the oceanic region, all these women need a repeat sugar test after 26 weeks of gestation. It's absolutely essential, because unmasking is happening in these areas, in these communities, only after 26 weeks. So if you are relying on something which is done in the first trimester as non-diabetic, and then expect right throughout the pregnancy that she would be non-diabetic, it will be a fallacy, and you need to redo the testing. And FIGO has recommended, we have Hema who is on that committee, who have recommended that whatever time woman comes in, you take a sugar level, give her 75 grams, test it after 1 hour and let her go, because she's not going to come fasting again. She doesn't have the time to come in the morning at 8 o'clock empty stomach, and she's not able to come. And this is enough, good enough to give you an indication who are the ones who are at risk of hypoglycemia in pregnancy. And you can then subject those who are at high risk, later on call them. And then at least the universal screening is must. Every pregnant woman must have this screening done. So you have the individual barriers to GDM, the lack of information, dietary message difficult, cost of healthy food, denial of condition, reluctance to accept insulin treatment, and lack of physical activity, space, safety concerns in him. Now let us look at the endocrinologists that are in this country. 1,000 endocrinologists. We are delivering a huge number. We are delivering each obstetrician today, 35,000 is supposed to deliver 900 patients. It's physically impossible for any obstetrician to deliver 900 patients. And those 900 patients, 17% are going to be diabetics. And if those diabetics are to be treated by only the 1,000 who are entire country endocrinologists, it's next to impossible. And I think it's time all of us pitch in and to be endocrinologists ourselves, to make sure that we treat the patients who are diabetics ourselves and not rely on the endocrinologists to, where they're available, fine, but when they're not available, you need to look into that. And therefore, the feeling healthy and not in need for care or fear of perceiving bad news is sometimes deters the patients from coming forward for any of the examinations. And you have health system barriers which are there. There's no knowledge of the links and a multitude of screenings and diagnostic procedures that are offered to the patient with the patient feels that you are taking them for a ride, or you have a contact with the pathologist and you are therefore sending them over to get all these tests done. So all these barriers are there, and there is no integration of services that are available, and inability to track and follow up cases is again a big issue as far as our country is concerned. So you have a societal problems, negligence of women's health. The women are the last priority in the family, low awareness, stigmatization, practice of perception, and the weight and the diet, which is completely at loggerheads with each other. And solutions and need for action is therefore needed, addressing the educational, political, and social issues, linking the NCD agenda to sexual and reproductive health, and providing access to maternal and child health services as well as care for NCDs at the primary care level, and avoid making best the enemy of better, ensuring protocols and recommendations are not merely academic but practical and feasible. There's no point in producing books and putting them on for everybody to read. Nobody reads them. And believe me, we are all practicing people. You get a book on your table with 300 pages which is supposed to give you all that information. Nobody's going to read it. It's just cover and that's it, and maybe see who's written it. That's about it. So you have the FIGO pragmatic guide, which is a very simple 4-page item which you can keep it on your desk and which will be able to tell you. You can see the recommendation. They are available on the FIGO website, the universal testing that I talked about, which is extremely important, to the other recommendation that the FIGO recognizes that management of diabetes in pregnancy should be made in accord with the available national resources and infrastructure, even without high quality evidence, as it is preferred to the alternatives of no or poor care. Because you are looking at RCOG recommendations where you must do a complete GTT at the beginning. How many of our women will come to do a GTT? None of them will come to do a GTT. So this is something which we need to, at the level of resources at various countries, that we need to do. And FIGO calls for public health measure to increase awareness and acceptance of preconception counseling, and to increase affordability and access to the preconception services. And it's important that we let the women know prior to pregnancy what are the important things that need to be done. FIGO encourages obstetricians to establish connections with family physicians, internists, pediatricians, all. Everybody has to work together in this scenario, because the obese pediatrician who doesn't look after the obese baby is going to become, the woman is going to be obese pregnant, and that is where we are going to face a problem. And therefore, it is important that we have diagnosis, quality of care, and which needs to be. So disseminate and share the FIGO recommendations and guidelines which are on the website. Talk to policymakers, government representatives about the need to highlight HIP, and join with other professional societies to ensure improving the testing, diagnosis, and care for women with HIP. So we need to have a call for action to support all this. And that call for action, it begins with the mother's nutritional status. We need to look at that point right in the beginning to make sure that that action is taken care of. And I welcome you all to our FIGO Congress in Rio, which is from 14th October to 19th October. And I'm happy to tell you already there are 600 Indians registered for the Congress. Thank you very much.